Welcome to our CHEP seminar this week. We're lucky to have Sara Markowitz, Professor of Economics from Emory University. She's also a Research Associate at the National Bureau of Economic Research. Sara is an editor of the Southern Economic Journal and also an associate.
I quit.
I see.
You shouldn't say that. My term was up.
Okay. Associate editor of the Journal of Health Economics, yes. And Review of Economics of the House. Yes, absolutely. So she's a leading economist on the economics of risky behaviors. Has published more than most anyone I know in the Journal of Health Economics. It's published in all the top field journals and great general journals as well. So we're really lucky to have Sara here to present her work on scope of practice laws. Thank you.
Oh, thanks. So I like to keep my seminars somewhat casual, so please feel free to interrupt and interject. So this is probably not the traditional seminar that you're used to hearing because this research is at a unique stage for me. I don't have any brand new research projects to share. I definitely have some ideas to continue this work. But so in the past spring, my co-author Kathleen and I finished this Hamilton project, which I see some of you have, and that was probably what was circulated. And so the Hamilton project is this policy piece that drew on our previous research, which got published last year. And then it took lessons that we've drawn from other literature on the topic. So here's the boring title up here. And then, of course, the title that got passed around was these scope of practice laws. In my opinion, the most important healthcare law that you've never heard of. Because typically when I talk to people about this, I get these lovely blank stares, unless you happen to have a relative who is a healthcare practitioner, and then you know all too well about these laws. Before I get into what the laws are, let me just kind of give you some big context, which was the driving force behind the Hamilton project. You all may have seen a graph like this before, which shows national healthcare expenditures for the U.S. As a percent of GDP, kind of relative to a bunch of other OECD and other countries. And what you notice, of course, is we're a little out of whack with the rest of the world. And I don't want to draw any main conclusions about this, especially in terms of quality and technology and what we're getting from that spending. But we are definitely spending a lot of money on healthcare in this country. Kind of the problems and the motivation for this study was looking at, well, if we do want to reduce this spending, how do we do it? And of course, over the last, 8 years, there's been a lot of national policy debate. The debates go on at the state levels all the time. How do we sort of bend this cost curve? How do we, reduce costs or at least lower the increase in costs? Right now, we're at a crossroads where policy solutions, it may be too hard to politically get to policy solutions. So maybe if we focus our attention of what we can do within the existing system, this might be a viable path forward. And so looking at the labor market within healthcare, this is kind of where we land. About a quarter of those national expenditures are on professional services. So the physicians, the nurses, the PAs, any of the professionals. And so our study really kind of hones in on that particular market there. Another tangential area that we touch on is about shortages. Okay? So as economists, we can debate whether or not shortages actually exist in healthcare markets. The big question is, if there are shortages, why don't wages just rise in order to eliminate the shortages? What we do know is that we've got parts of the country that are designated as medically underserved, and there's a specific definition that goes along with that, and that if you use that definition, we definitely have shortages. And then there's a lot of ink spilled about projected shortages with the aging of the population, and if the ACA continues to be law, Medicaid, if that continues to get expanded, that's going to create pressure on demand for services. So all of these things we want to touch on, or the motivation for looking at the labor force within the healthcare industry. Okay, so back to the big question. What are these scope of practice laws? All right, so here's the official definition here. They are actually the legal authority given to these licensed care professionals to provide medical services within a state. Okay, so let's be clear. These are state-based laws. Okay, the healthcare professions are licensed. This is what happens after they get their license. So they usually, to get your license, you go to school, you pass national exams, you get some hours in practicum, something like that, you get your experience in, you get your license. Okay, but so then from there, that's when these scope of practice laws kick in. Okay, they basically say what the practitioners really can and can't do. It's about oversight. Who's watching over them? How do they go about their daily business? And I'll give you much more concrete examples. Okay? But specifically, these scope of practice laws govern what we call the advanced practice providers. So the APP is the acronym there, which includes advanced practice registered nurses, physician assistants, optometrists, dental hygienists. There's also some therapists. There's a whole bunch of other healthcare professionals that fit into this category.
Sorry, so what's covered under advanced practice registered nurses? What additional?
There you go. Okay. These are what these APRNs are. Okay. They're nurses who've gotten their bachelor's degree. Okay, so the generalist nurses you've heard of, the registered nurses and the licensed practical nurses. So they get their nursing degree first, and then the APRNs go on and get either a master's or a PhD. And these are the four main types up here. So the nurse practitioner is kind of a general nurse. You may or may not have come into contact with them if you've ever gone to a retail clinic. Do they have retail clinics in California? Like CVS or Walgreens?
Yes.
Yes, okay. So those are typically staffed either by NPs or physician assistants. So a physician assistant has 3 years of schooling beyond the bachelor's, and they can do a lot of stuff that a general practice physician could do.
Excuse me?
Yes?
I don't know if it's politically correct, because I see Brookings Institute is involved in this. But Milton Friedman, I mean, the first person I thought about when you started speaking is Milton Friedman.
Okay.
Because one of the things that he advocated is, more free markets in the medicine.
Yep.
And he was a big foe of the American Medical Association.
Yep.
And he didn't specifically write about nurses, but the whole idea of having those licenses and those limitations, something Milton Friedman wrote about.
Yeah. I'm not actually familiar with that writing, but I can tell you that the AMA does not like me either. And you'll see why. I'll have to look that up and see what he says.
It's a chapter in Capitalism and Freedom.
Okay. All right. Yeah, and occupational licensing in general is kind of a hot topic. So actually, if anybody's looking for good dissertation topics or research topics, there's only a small group of researchers doing this kind of work, and it's amazing how much it influences labor markets these days. And we could talk about that more. There's all sorts of good stories in occupational licensing.
And it's been expanding, right? As union has been declining. Is that
Yep.
the idea?
Yeah. And it serves as protection.
Yeah.
And that's what my story is going to be too. It's protection. Okay, so the certified nurse midwives, these are nurses who are trained in all aspects of pregnancy, labor, delivery, and they're a very small portion of that healthcare world, but growing in popularity. So for example, like in England, their National Health Service just set out a mandate that all women who have healthy pregnancies should be using a midwife rather than an OB for delivery. And then, so the other two, these are specialists. So actually that's a better slide than this one. So just to give you an idea of where this is going, is that physicians do not face scope of practice restrictions generally, right? They're licensed, the states basically say, go be doctors, go practice, and do no harm, okay? The scope of practice then pertains to these groups here, and so this group is going to oversee this group, and same thing with dentists, they're going to oversee these groups. And so that's where this oversight is going to come in. Okay? So this just gives you an idea of the size of the labor force we're talking about here from 2016. So it's a fairly substantial portion. Okay. All right. So I'm going to focus this talk on nurses. A lot of it can pertain to the physician assistants, the dental hygienists, the chiropractors, the optometrists, and so on. But nurses is where my own research started, and I think they're the easiest case to talk about. Okay. So what these nurses are trained to do are basically all of this. So they go to nursing school and they learn how to examine, how to diagnose, right? How to provide the tests. They learn about pharmaceuticals, all this. This is all in their training, okay? So then the laws come in and they basically say, all right, even though you've been doing this training, we're going to oversee you. And there's two main ways they're going to do it. One is this practice authority, which basically says the degree of practice independence. So given that they've been trained like this, what can they do with and without oversight? Okay? So the most restrictive states have physician supervision required. So the laws basically will say something like, you know, in order to practice, you have to have a formal relationship with a physician overseer. And I'll show you details about that. That's the strictest. A lot of states then have what we call collaborative requirements with or without protocols. Okay, so these are, again, another form of supervisory type of oversight. Again, I'll give you details in a minute. And then there's also states that have no specific requirements, which treat the nurses the same way they do the doctors, and that basically just says, go practice up to the level of your training. Okay, so nurses are not going to be doing surgery. That's not what this is about. This is about what they're trained to do. Okay, and then the same thing for prescription authority. Yes or no, can they prescribe? Do they have to have physician oversights, and which drugs? Okay. States are moving towards what we call this fully authorized scope of practice that basically eliminates all the physician oversights requirements. Okay, and my little asterisk here is thanks to my nurses that we've worked with that basically say that professional standards have them all working in collaboration. These are not independent silos. The practitioners all work together. You know, nurses are going to refer cases when they need to. This fully authorized SOP is without the administrative burdens that the states are imposing on the practitioners. Okay, so let me give you the examples now. This is a map from 2017 of the states that have this fully authorized that I just talked about versus all the other levels. So it could be the collaborative, it could be these protocols, it could be supervisory. Okay, you definitely, I'm sure you'll notice some geographic distinctions here. Okay, that if you're looking for patterns, the pattern you want to look for is rural, non-rural, really, with the exception of the South. You'll notice California is not fully authorized, and I will show you. I'll show you California's laws in a minute. But here is Wyoming. So Wyoming is one of the states that has this fully enabled law. You know, it's a very rural state, and this is straight from their administrative code. Basically, that these nurses can do this. They have responsibility for direct care management. They can do basically prescribe, administer, you know, drugs, everything. They can do it all, up to their training. Okay, so that's what the law looks like. It's very short in Wyoming. Okay, here's California's laws. And ooh, Joe, can you help me with? Okay, I brought this. I wanted to show this to you. But all right. So before I get there, so nurses in California. The advanced practice nurses are basically under supervision, okay? So they have to work under these standardized protocols developed with, it says in collaboration, but it's really with a physician. And it says exactly when and where and how they can perform anything, okay? There has to be periodic review of these procedures. And importantly, physicians cannot supervise more than 4 nurses at a time. Okay, so this is effectively protecting the physicians, right? It's putting a cap on the number of nurses that can practice tied to the number of physicians that are willing to supervise. Okay, so I don't know if that link is going to work. But so what this link actually has here is some details, gives you an example of the protocol. So a protocol is actually a piece of paper that's signed by the nurse and the supervising physician, which clearly outlines what they can and can't do. Okay, so this is straight from California's Board of Nursing here. So you can see you've got what they can diagnose, the plan, record keeping, all this stuff gets in there. And then there's actually some more specific examples in here. I wanted to show you, what to do if there's a problem. All this stuff goes in there. They all sign it. Here you go. So this is, again, step by step, what these nurses can and can't do. And then specifically, it goes on, and they have a formulary here. Okay, look, if you see these problems, these are the drugs you're allowed to prescribe. Okay, so it gets that detailed. Okay, so that's all I wanted to show you on that. Okay, and then from the Board of Nursing, they actually gave me this nice kind of summary of how to think about how nurses are treated in California. Here, where it says the NP does not have an additional scope of practice beyond what the RNs are allowed to do. So it's very restrictive. And they have to then, anything above the RN, use these standardized procedures, these protocols to perform, quote, overlapping medical functions, right? So with that language, you can see that they're doing exactly what the doctors are doing, okay? And so they want the doctors to be involved in that. And that has actually big implications for this whole market, which we'll get into, okay? And so, the second paragraph basically just says, nurses ask if they really need this, and then yes, they do according to the law. So, yeah.
I think I know the answer to this, but is there a larger number of licenses suspended in states with more SOP regulations? Does that follow, or?
Of licenses suspended, you mean for malpractice?
Yeah, are there higher rates, or?
So, it's a good question that I have not yet found any data on. It's actually on my research agenda to look at. There was one paper that looked at physician liability, and that goes down when you fully enable. So, liability issues tie into all of this for sure. Okay, I was just in Alabama last week, so I showed them their restrictive laws, which are very similar, but they also have the full restriction of 4. They had some physician has to be present, so right there with the nurses for a certain amount of time, chart reviews and so on. Georgia, my state, is also very restrictive. What's interesting about Georgia is right here. They specifically say, again, it's collaborative with protocols. They can order drugs, all this with the permission, basically. And only in life-threatening situations can they order a radiographic imaging test, which basically means X-rays. So nurses in Georgia are not allowed to order an X-ray, okay, without a doctor's permission. And there was actually a bill up this legislature trying to change that, and they voted it down. Now, years ago, Georgia's a funny place. I have no problem making fun of Georgia, so you don't need to edit this out of your thing. In the early 90s, the state of Georgia passed a law about restricting scope of practice, which basically said that the only groups that could pierce the flesh were doctors, dentists, and veterinarians. That was it. And so, of course, the state got sued, and it got taken to the Supreme Court, and it was struck down. And the reasoning was you could not nobody could give you shots. Diabetics could not give themselves insulin. You couldn't get your ears pierced without a physician, a veterinarian, or a dentist. And because the law specifically said flesh, dead or alive, you couldn't cut your chicken dinner. Okay? So that got struck down. But that's what they did in Georgia. I love Georgia. Okay. So, in thinking about, all right, what are these laws actually doing? We have to separate out kind of big market pictures, which is the next slide, from the day-to-day. So this slide is really about the day-to-day operations, okay? So here's the direct effects of these restrictive laws, okay? It requires administrative burdens. It's additional documentation. So doctors will have to either co-sign for orders, or they have to sign off on them. They have to do chart reviews. Okay, all this can generate delays in care, and this is what our nurse colleagues told us, is that, if something goes off the protocol, off the formulary, you have to wait and call the physician. Well, if the physician's busy, you have to wait for them to call you back. So that, can harm the patient because of these delays. There's disruption in the continuity, where these medical records, everything has the physician name on it, so it's got to go to that person rather than the nurse who's actually caring for the patient, and so on, okay? We talked about chart reviews, so there's time barriers there, or time away from patients, okay? And then, of course, the big thing I've already alluded to is these barriers to new practice, where you have to find a physician to enter into the CPAs, the collaborative practice agreement. So you've got to get somebody to agree to work with you. And then, of course, there's fees associated with that. Okay, so then kind of bigger picture, and what we care more about is really how are these affecting the markets. And so, my talk's going to focus a little bit on all of these things, but there they are. So there's the list. I've already talked, yes?
So I'm curious, transaction prices?
Yeah. So that's our term for the price of providing a medical service,
Okay.
which in the world of health with insurance is really actually very hard to measure.
Okay,
So that's what we need.
gotcha.
So some people use insurance claims, so forth. Okay, controversial. Frequent legislative battles, I've already mentioned that. So if you're really interested in this, the National Conference of State Legislatures has a really good webpage just devoted to scope of practice laws. And so they counted 139 bills last legislative season, with 37 inactive. And basically, the critics, the AMA, medical associations, are going to say it's a quality issue. Okay, that's their argument. And so here's a quote from one of them, basically saying that if you grant independence to these nurse practitioners, you would get two classes of care, one run by a physician-led team and one run by less qualified health professionals. Americans should not be forced into this two-tiered scenario.
So just a political economy sort of question about how these get enacted. So are most of the battles sort of each year on amending sort of existing scope of practice laws and sort of what other procedures we might ban, we might prevent okay, so that's...
Yeah, so the fights these days are the practitioners trying to eliminate the oversight requirement. Scope of practice is not a great term because it implies that you can do more, right? So with the exception of going from no pharmaceuticals to pharmaceuticals, they're not doing any more. They've been trained to diagnose, treat, and all that. It's just about eliminating the oversight. Yeah, except in the teeth whitening for dental hygienists. So that would be an expanded scope. That's a big fight. Yeah.
Is there any good descriptive information on the transaction prices between like a general physician versus like these nurse practitioners doing the same type of service?
That is a good question. Can I punt that to later in the talk?
Sure.
All right. Yeah.
In some other things I read about the AMA and Milton Friedman, the military seems to have been a force that has moved towards more competition because they are nationwide.
Yeah.
And so are you going to address anything about the role of the military in
Not
this?
really. There's a box in the Hamilton Project that talks about what the VA hospitals did, which was expanding the scope for everybody but the nurse anesthetist. And if you read the Federal Register as to why, it was because they bought the arguments from the anesthetist who said, we don't need any more, we don't have a shortage. And so they protected their turf. Okay. So then, of course, the proponents are basically going to say, look, quality's not an issue, and we can expand access to care. So they have a lot of arguments on their side. Let me just briefly point out that these groups talk about studies that analyze, they compare care between NPs and the relevant physicians, and you typically will find either same outcomes or, better outcomes in this comparison. But there's a huge flaw in a lot of this literature is that they don't account for the scope of practice environment. And so a lot of these studies are done under supervision. So it's useless for this particular debate. And that's really highlighted in our first paper. Okay, this is just a public policy question, so I think I'll skip that.
Sorry, can I ask one more?
Yeah, please.
Regarding the sort of changing legislative environment, are there a lot of large shocks, policy shocks, or are they more kind of like this marginal sort of adjustment?
Well, the big ones have been going from some type of collaborative practice agreement to the fully enabled. So that's really a large policy shock.
But does that like end up being like kind of a creep? Like a slow like evolution to fully enabled? Or are there any states in which there's this kind of like pretty big discrete
No, you can see that discrete shock for sure. You can. You can also see it going backwards in a couple states where they've gone from less restrictive to more restrictive. But it's really state by state. Like some of the states, like New Mexico, has always been very favorable to midwives, and that's kind of part of their culture there. The pharmaceuticals, not pharmaceuticals, has been a big jump for many of the states there. So it's kind of a mix of what you're asking about.
Okay. And off the top of your head, do you know when a lot of sort of big discrete shocks?
It's been going on continuously. We started our collection in 1994, and you see action very frequently. Yeah, all across it. Okay. All right, so I'm going to kind of tear apart now these components of the big picture. So thinking about first the labor market and starting with the labor supply. So we wanted to think through, well, what happens under the restrictive environments compared to fully enabled? And so, just talking about, what determines that labor supply curve, what may be going on here, we can identify that under these restrictive SOP environments, we think that they may discourage people from even entering the profession. We can maybe see restricted hours, administrative functions. There's actually a lot of nurses who are licensed and trained and not practicing as nurses, probably for various reasons, but the trouble finding a physician to enter into one of these CPAs with may be one of these reasons. We might expect to see migration from more restrictive states to more favorable states. And then I already mentioned the supervision ratios that limit supply, and so that's what this next slide just tells you, which states have them and what the ratios are. Okay? So it's not an insignificant number of states here that are doing this, that effectively are limiting the supply and tying it to the physicians, which makes, I think, analyzing these labor markets is pretty interesting when you have a tying like that.
Have there been changes as well in sort of the number?
This does not change. And I'd love to know what's going on in Oklahoma there, 2 to 1. So that's 2 nurses to 1 physician.
Sorry, I think is this mandated or is this observed?
This is in the state statute.
Oh, in the state statute, it requires that you have, is it no more than
Right.
4 nurses for every
Yep.
physician? Okay.
Yep, yes.
What do you mean by 4 offices?
That's Florida. So it's a physician office. So I'm not quite sure how many nurses they can actually oversee there, but they physically, in the law, it says offices. And I'm sure somewhere it defines an office as a group of practitioners practicing together, blah, 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 blah. Yeah. Okay, so that's just the supply side, and then from the demand side, there's a few things to consider. One is just certainly, how does this affect the marginal productivity of both the nurses and the physicians, right? 'Cause we talked about all this administrative time. So we would expect to see decreased productivity of both in these restricted states. And limiting the scope of their services can reduce the value to employers. So there's my Georgia example. If you can't have somebody ordering an X-ray for you, what good is that to your firm? There's all sorts of issues about substitutability among workers. Again, going back to now, if they're tied together. These laws, it really has implications for the opening of new healthcare facilities. So I'm trying to think about, what does that labor demand curve look like? Who's demanding the labor, right? And one model you can think about is a private physician practice that just hires nurses. Another model you can think about is the retail clinic, where a corporate conglomerate is coming in and saying, we're going to open all these facilities and we need to staff them. And then another thing that's not really on this slide is about the legitimacy that these laws give the nurses. So like when the England's National Health Service comes out and says everybody should be using a midwife, that gives a lot of credibility to these practitioners. And so when a state does that too and gives kind of their stamp of approval, you can see the demand for those services shifting out. So we kind of got all those things mixed into this labor demand curve. It's a little difficult to cleanly think about, but those are some of the issues. Yeah.
Would we also think that like HMOs and managed care organizations might be contracting within these places where there's more scope of law practices because they can't necessarily substitute cheaper labor for the more expensive, say the physicians and whatnot?
Yeah, absolutely. No, that's a big issue. And, I'll talk about it a little later, but a lot of the new models of care are going to require substitution between these labors. But remember, the nurses are trained basically to do the same thing as general physicians, right? For a set of conditions, they are perfect substitutes. Okay, there was another question?
Yeah, I was wondering, so I don't know if you've looked at this, but if you've looked at kind of the ratio, the observed ratios of doctors and nurses in these different states, and whether that varies, aside from the states for which it's mandated, and I wonder, for the states for which it's mandated, does that seem like a binding constraint, given?
Yeah, that was the motivation behind my first labor slide.
Okay.
Because I really wanted to see if you could see it, right? The data are not that clear, So some of the problem is you can drill down and you can find out number of physicians, even in a county, and you can find out the nurses. You can do it by specialty, so I could get GPs. But the problem is that you don't know where either group is working. And so these laws typically do not pertain to hospitals. So hospitals are going to have their own rules. So that's why I'm kind of steering the conversation towards the standalone doctor's office and the retail clinic. Okay. So considering what we think is going to happen in the labor market with supply and demand, we think that the movement to this fully enabled SOP will unambiguously predict higher levels of employment of the nurses, equilibrium employment. The wage effects are indeterminate. You're going to have supply moving out, demand moving up, so we don't know what quite would happen to wages. I posed the question, does this mean greater access to care? That's kind of a different question than how many nurses are working. Are we just going to substitute amongst the providers, or do we actually increase the size of the market? And that would happen if we see this legitimacy story going on. So these are all empirical questions. And then getting back to the big policy debate, where the question is about quality, none of this says whether or not quality of care will change. It's an empirical question. We do want to mention, though, that there's potential for spillover effects on the physician practice, that if these laws, reducing these laws, actually alleviate shortages, it could potentially mean more time to spend with patients on all sides, and that could increase or alleviate the shortages there, increase patient quality. And then one thing we found from our midwife paper is changes in practice style, and so we might see competition actually having some benefits to patients there.
So thinking about the quality of care stuff and what's driving I mean, there's a lot of things that are driving the specific provisions in these laws that are prescribing exactly what you have to do in particular circumstances. So are these particular margins of quality of care outcomes when there are more sort of subjective decisions that these nurses and doctors are making? Is that the primary margin where we might expect, if there is going to be any reduction in quality, that it should be on those margins? Do you have any sense of that?
Yeah, I mean, it's really hard to actually figure out what kind of quality we're talking about.
An X-ray.
Right? Yeah. So I'll show you the literature on it, and I think some of the outcomes people look at are just out there. It really shouldn't be affected at all by these laws. But so that's the intangible. It's actually really hard to measure the quality that would be affected, right? Because we can look at malpractice, some of that we can look at. We can look at some very severe injuries and things like that. But like the delays in care, you're not going to measure the pain and suffering from an individual who had to wait to get the phone call back from the doctor to get their prescription approved, things like that.
To also address the interstate effects, like the states in proximity to a state that has fewer restrictions. Do you see migration of patients? Do you see higher rates of,
Yeah, not
you looked
patients.
at that?
I mean, we haven't looked at that. One of my grad students is looking at the labor market migration, which we have some data
but
on.
the more interesting part is
Patient.
whether clinics are open up. I would imagine if there is a state that has less restrictive rules next to a state like California, then people would just go over there to get care because it would be cheaper for any given quality.
It's possible. The border populations are, it depends what their insurance is going to cover. There's going to be a lot of complexities there. Yeah.
Can I ask about costs and why that does not seem to be on your slide here?
It's coming.
Okay.
Yeah. Well, and part of it, how do wages feed into healthcare costs? That's not clear. I will talk about reimbursement in a little bit.
So it's a little bit of a loaded question because I dipped my foot in looking at this, but from a cost perspective.
Okay.
And looking at your this graph from the paper, a lot of the highest cost and highest growth rate costs states are the ones with no barriers.
Okay.
And I'm super interested to see the results on the anti-competitive angle because I think that probably has something to do with it. But it almost seems like to move in the opposite direction of your quality measures and the sort of real outcomes.
Well, so and because total expenditures are P times Q, right? So if quantity.
Yeah, but looking at like service breakdowns, it's not just in the aggregate dimension, but even on a per capita or even individual service costs, you still get this sort of differential trends that are very kind of puzzling.
Okay. Maybe we can talk more later?
Sure.
Yeah, no, I'd be really interested to see your stuff, your toe dipping, if you will. Okay. All right, so the next part of the presentation, I thought I would just give you a brief overview of what we published last year. And this was about the midwives. So Mary Jane is a certified nurse midwife, and Anne Dunlop is actually a MD. So we had the full team together. So I've already said this basically. These are the nurses that can do births for healthy pregnancies. Let me be clear, they are not allowed to perform C-sections. Their style is very different from that of an MD. It's much less medically intensive with technology. They spend a lot more time with patients, a lot more advice, nurture. It's a very different model. So this is just kind of the trends over time from first years. So we define the laws based on four categories of laws. High to no with the two in between. So the dark red is the highest barriers. And so you can see states have been loosening, and these are just for midwives. These are not for the nurse practitioners. Some states will have different laws for the two groups. That's just the laws. So this is very straightforward reduced form models where we've got a bunch of outcomes. looking at the laws that were in existence at the time of conception, controlling for a bunch of other stuff, state your dummies, state fixed effects and so forth, and some county level characteristics. So this is a really standard panel data model there. And we do some models just on medically underserved area. So the important thing to know is that 93% of births in this country are performed by OBs. Okay, so the midwives make up about the rest, 7%. There's like 1%, which is the taxi drivers. Keep that in mind when I'm reporting on these results, because the vast majority pertain to outcomes from births by OBs, okay, not the midwives. We do a bunch of results conditional on having a midwife birth, but the results are really the same. Okay, so we look at a bunch of health outcomes, and then these are just the models. We try to get at all those mechanisms that I was talking about. So we look at some employment levels, we look at who actually attended the birth from the hospital records, and whether or not the birth was in a freestanding birth clinic. So freestanding birth clinics are a new trend. They are less than 1% of all births, but these are just clinics designed specifically for birthing. And they're typically staffed by midwives.
Sorry, attended birth is just present at some point during
Person who physically yanks the baby.
Got it, okay, sorry.
Right, so then this is the thing. The data are horrible on this, because the midwife could be there, for all of pre-pregnancy, pregnancy, labor, and then the OB would step in, pull the baby out, and the OB gets to bill and gets to credit. Okay, that's how it works. Okay, we have lots of estimation concerns. It's all well spelled out in paper. We're very concerned about sample selection in this, right? So if you have prior knowledge about health outcomes, you may be more or less likely to choose a physician. Okay, so what we do, we limit the sample, singletons, first birth. So we get rid of the twins, they're always delivered by OBs. First birth, you don't have that prior health knowledge, okay? It's a reduced form model, so we're looking at state laws which are set by legislatures who are influenced by lobbying groups, and those should be exogenous anyway to the health knowledge from the women who are giving birth. So we feel pretty solid about these being exogenous here. Okay, so here's what we find. For quality, no difference based on the restrictions of the laws in all these outcomes. Early prenatal care, probability of smoking, drinking, correct weight gain, probability of low birth weight, and birth injuries. No difference whether you're in a state with a restrictive law or totally unrestricted. We see some small improvements in these less restrictive scope of practice states for birth weight and gestation weeks, but if you look at these magnitudes, and if you know anything about babies, those are incredibly small, okay? The average birth weight for a baby is about 3,900 grams, so we're seeing a change by 7 to 11 grams. Yeah, that is nothing. Reason I can get statistically significant is I have the universe of birth records from 1994 to 2013. Yeah, I'm getting statistical significance. Okay, there's no two ways about it. Which is actually really interesting that I get zeros on all those outcomes. Okay. Yeah.
So when you say small improvements, this is from looking at the tables, the reference group here, the states that have no scope of practice restrictions.
Correct, the fully
And then
enabled.
You have the low, medium, and high. So when the small improvements at less restricted, those are kind of the lower medium coefficients relative to those that have none.
No, I flipped it for this. So these are, these should be the coefficients. Are they negative in the tables for the high barriers? Let's see, birth weight, yeah.
For the high thing.
Yeah, so it's
okay.
from the high and the moderate and the low. Actually, yeah, all of these. So the negative. So I flipped it for this slide. That's all.
So, and what size effects can you rule out, given how precise these are for the no differences? So,
Yeah.
sort of.
I didn't test it.
Okay.
Yeah, I didn't look.
But
Okay.
presumably very tight.
Yeah, yeah. But I will say, right, so if you know anything about the literature on gestation weeks, right, it is really, really difficult to get that to move from any policy, right? This is when the woman goes into labor, it's almost a random thing. right? We really don't have good policy information on that. So actually seeing some kind of movement in that was really strange to me. But I have a good explanation, which is, boom, this one. So these are our outcomes. Now remember, nurses cannot perform C-sections, okay? They can prescribe in some states pharmaceuticals to induce. They don't like to do it, okay? So these are kind of the coefficients you want to look at here. So in these states with these barriers, we're seeing more C-sections.
Huh, that's really interesting.
Yeah.
So Sara, I mean, the fact that you guys don't find an effect is to be expected, right?
Right.
Because of what you were just saying.
Yeah.
So basically you have the nurse doing all the work throughout, and then basically the guy shows up, the doctor, okay? So it should be the same outcomes in birth weight, right? All those things.
Yeah.
But I was thinking, I don't know, to me, for example, it was actually reassuring that if something happens or whatever, I have the doctor there, and he is a physician, and if there's anything at the last minute, and that's, even if it's a small chance, whatever that is, and I don't know anything about, but he's gonna be able.
Right, and that's how they practice in real life, right?
Yeah.
They absolutely collaborate together, and any midwife is going to have a relationship with an OB. But remember what these scope of practice laws are doing. They're saying you can't practice unless you have this agreement in place. You have to get the doctor's approval for, like to prescribe, I don't know, Tylenol with codeine or something. If you break your arm during pregnancy, right? I mean, it's these types of things. That was a bad example.
Really bad pregnancies.
No, but my concern is that, okay, you have the birth, you are with a midwife in one state that basically you don't need supervision by a doctor. Something happens.
Right.
Okay, and now the midwife, where's the doctor now? Okay, I've been helped by a midwife, now I have to build a relationship with a doctor, or not even, I'm not going to be able to build a relationship because it needs to be done immediately. Okay, and I think that, I don't know, I think for me, for example, it was reassuring to be able to know that I have this relationship with this person. He's a physician, if something goes wrong at the last
No, but
minute.
in practice, they do work with physicians.
Okay.
It's just without the piece of paper. That's
But
all.
they are going to be supervised in practice too? No, only
No.
if they are in one of those states, that's what I mean. Yeah.
No, so like, all right, take the model of freestanding birth
Yeah,
clinic, right?
yeah, yeah.
So it's jointly staffed by physicians and the CNMs. And so as a patient, you might see the CNM the whole time, but if something goes wrong, that physician's on call and that physician will be there, whether or not you're in a restrictive or a
But
completely
I never see the
independent.
physician.
Huh?
I never see the physician before.
Right.
Yeah, that's it.
Yeah. Yeah.
That's what I was thinking, that's probably what it's in the behind of, at least it would be for me. Like, I would be like, hey, I want to know who the doctor is and I want to build this relationship.
Yeah.
Yeah.
So what would be the mechanism here with like this apparently elective induction and the elective C-section? Because that's a decision that's made not like in the moment, it's made like
Right.
earlier.
Right.
And so
Yeah.
it's not obvious to me
Nope.
why you'd be seeing this significant effect on those two.
Yep, it wasn't obvious to us too. And the story we come up with is the threat of competition. That's our story, and that because there's such a different practice style, and there's actually, I hate to call it a fad, but maybe more of a movement of women seeing midwives for births, because you've heard, for decades now, there's been these horror stories about these inductions that lead to C-sections that are unnecessary, and women going through the torture of this stuff, where the midwives are much more patient. They're not going to rush you through the whole process. And so we think what's going on here is that when you have more midwives in a state that can take away the business, the doctors might be forced to change their practice style. And that's why we think we're seeing less of all these things. That's really the story we can come up with.
What about mortality outcomes for both mother and child?
Yeah, we haven't looked at that here. But that's a good outcome to look at. Okay, so just to put some of these numbers in perspective, it's again a fairly small number. So just looking at that C-section, we're reducing the proportion by about 7.5%, so from 23.5, so a quarter of all births are C-section on average during this time period, to about 23.4%. And so I just put some numbers on it. Basically, it's avoiding about 24,000 C-sections. They cost about $4,000 more than a vaginal birth, so you save about $100 million per year. So when we're talking about the costs, you know, this is one estimate we have of some potential savings. Okay, I'm running out of time. I can see this. So let me skip that. Okay, let me skip all that. Okay, let's go to the other studies. So for our Hamilton project here, we did a literature review of what we consider the high quality studies of these SOP laws. We only identified 13. Okay, so there's not that much research out there. Okay, but here's what that literature finds. In general, what we predicted about the labor supply and the labor market has shown up empirically. Okay, so that's all I can say there. There was only one study by Morris Kleiner about wages, and my problem with this study is that they actually separate out this practice authority from the prescription authority. In talking to our nurses and doctors, there's no way you should really be able to separate out those two. They go hand in hand. So he finds differential results depending upon which law you're looking at. I think this study probably needs to be redone in order to combine those. But no effects on wages, basically, is what he finds. Okay, utilization and access. So we do find from the literature more probabilities of routine checkups, office-based visits. So this is all within the fully enabled in either practice or prescription. Again, every study is going to define it differently. There's no uniformity across the literature on how these laws are defined. But a higher probability of usual source of care, getting appointments, so that kind of gets at this, how they're allocating their time. We see a decreased probability in these emergency visits for ambulatory care sensitive conditions. So these are conditions for which if you had appropriate and timely care in a physician's office, you should not be showing up in the emergency room. And so that's actually a very important result, we think. But then other studies really find no effects on some of these other measures of utilization and access. So again, it's in its infancy, this literature. This is where it's at. Yeah.
So states with more independent SOP, they have greater access to like prenatal care. Is that included in talking about routine checkups and more office-based visits?
That was all NPs. They didn't look at the prenatal care.
Yeah, no, that's what I was sort of getting at, preventative care versus not, has there been any pattern that's sort of showing up?
Yeah. It's
okay.
Yeah, it's just kind of mixed. You know, it's one study with no usual source of care. You know, you saw the numbers from the labor market, right? These APRNs are still a small fraction of that whole labor market there. Okay, health outcomes. This again, where it gets very strong. The studies have looked at these outcomes here, no difference based on the law classification, which is really starting to hammer home the point that the lobbying groups who are saying it's a quality issue have no evidence behind it, okay? And then one study actually saw better self-reported health status in these fully enabled states. So that's that. All right, prices. Okay, a couple studies, a few of them here, that basically find lower prices of well care visits. That was insurance prices, I think. This middle one, again, looks at insurance claims and how much out of pocket the consumers are paying. And so they're looking at these retail clinics specifically. So again, lower prices with the fully authorized SOP. And then another one on claims for Medicaid. So we're starting to see evidence that the in-states with these fully enabled laws have lower prices. Okay. All right, so why? All right, now I get into some of the details. So Medicare, of course, the biggest public insurance program, they pay according to the schedule. Okay? So it is built into law that if you get a checkup by a physician, the physician will get reimbursed at 100%. If that exact same service is done by a nurse practitioner, the nurse practitioner gets paid 85% of what the physician gets. Okay, so the cost savings are actually built into the system. Now we could debate whether or not that's efficient, or I don't know, you could get into some other arguments, but that's what Medicaid does. Okay, so you can see if you can switch between practitioners under Medicare, you can achieve cost savings. It's plain and simple algebra. Yeah.
So do patients see the same like, co-pays or co-insurance rate?
Yep.
Okay.
Yep. Yeah, this is the reimbursement side from Medicare to the physician practices, so it's savings from Medicare is where the savings would come in.
It seems to me that the AMA and some other lobbying groups have had an impact on these fee schedules,
Oh yeah, for sure.
because there's absolutely no reason why certified nurse midwives should be reimbursed at the same level as physician fee schedules, and that's just because they don't want the substitution to happen.
And that's how Medicare works. And so there's a group of physicians that set reimbursement rates, and they've actually studied this, and you can actually see when the group is heavily staffed by a certain specialty, the reimbursements to those specialties go up. So yes, it's all very much tilted. Okay, total healthcare expenditures, prices going up, quantity rises, what happens? You know, we're going to argue maybe in the long run you might see savings if you can actually see the increase in preventative care and a substitution away from expensive hospital care or ER. And so that's where this other study came in that I mentioned. And so they just put some numbers on it. And so they came up with an annual cost savings of $543 million. Okay, which is a nice number. I'm sure everybody would like to see. And then our study, I already told you about that. So, but these are the only two estimates we could find in the literature. Okay. All right. Let's skip that. Okay. Now the next thing. This one we learned about recently, and this is really shocking to me. Okay. There is a practice within Medicare called incident to billing. Okay. So what it is the first bullet up there. Services provided by these advanced practice providers, so that includes the physician assistants, they can bill under the physician's identification number and get paid according to physician fee schedule. Okay? So I just showed you, right, nurses are getting 85% of physicians, but if they submit under this incident to billing program, they collect 100%. Okay? Right? You should all be shaking your heads now. Okay, so what is this? It means part of the rules are, the second bullet, you have to be under direct supervision of the physician. So the physician physically has to be there down the hall. Okay? So this is a second layer of scope of practice restrictions imposed by Medicare and often followed by commercial insurance companies that in effect negate whatever the state has done. Okay? All right, so if Medicare could remove this billing requirement, we would actually get paid according to the initial fee schedule that I just showed you, so that would lower costs.
Which is already bad.
Right. Okay. And you would actually be reimbursing the provider who actually did the services. And from a researcher's perspective, this policy is horrible because we don't know who's actually doing the services because it gets billed under the physician. So physicians can be getting all this credit for all this work that a nurse and a physician assistant is doing, and it doesn't show up in the claims. We would never observe it.
Was this a rule change with Medicare? Is this what it's been?
This has been, yeah. Now, it's very specific. It's office-based services, and there's a whole list of qualifications for it. But yeah, there you have it. So we don't know who's doing the services, you know, transaction prices, you know, it's all hidden.
Are you going to get to the political process of how these Medicare incident to billing, all these things are established? Which committees are doing this? Which politicians? Who are the idiots that we are paying creating all this?
I refer you to slide 1. 17.9% of GDP. Yeah, Medicare cannot negotiate for pharmaceutical discounts, right? CMS needs a massive overhaul by an economist. That's all I'll say. Okay, so these are kind of, since I'm totally running out of time, the last three things I want to touch on. So, thinking about what are these scope of practice laws doing, let me talk about the medical liability, okay? So just like physicians, nurses can be held liable. If they're supervised, they can pass that on, a substantial portion on to their physicians. So this is a benefit that the physicians have not really picked up on. They're worried about protecting their turf and not having the competition, but their medical liability would probably be much lower. And there was one study that looked at it, and so this is what we were talking about earlier, that you can find lower malpractice rates, which is basically payouts per 1,000 physicians, that in the states that have eliminated these supervisory requirements. So you see the doctors are getting sued less when the medical liability falls directly on the nurses. However, this particular study, I don't know why they didn't study nurse malpractice payouts. You can, the data are there. I would like to do it. I may, we'll see when I get to it. Okay, but so here's my favorite story. I was preparing for these lectures, because I just gave this last week also, and the AJC, this is our Atlanta paper, came up with this fantastic headline, okay? And this is why you'll never forget this talk. All right. Verdict in Clayton botched circumcision could be national record. So they awarded $31 million for a botched circumcision case on Friday. And basically it was done by a certified nurse midwife who messed up under supervision in Georgia, okay? And so her insurance company had to pay half of that. The supervising obstetrician had to pay 30%, which under other independent scope of practice probably would not have to pay. And then the clinic's owner and the boys' pediatrician, they also got sued.
So how much damage are we talking here?
Read the second paragraph. That's why I put that up there. See it in the back there?
Oh, I know the shoes.
Ouch.
31 million seems low.
In the last seminar, they asked me what the value of statistical life is, because I think the value is only something like 8 million, 12 million, something like that. And my response was that, this is a baby, right? They've got a long life to live. So. Okay, there you go. So this highlights really the issue with the medical liability. All right, now you'll never forget me. Okay. Retail clinics, so these are other issues. The retail clinics, that should be pretty obvious on how these restrictive laws are going to affect. Telemedicine, this is new innovations in healthcare, right? But now we have this problem where you potentially could have people crossing state lines with different rules. And my understanding of this is that you have to do the rules and regulations where the patient is located. And so if that's going to have supervisory, if you're going to give telemedicine by a nurse, then she's going to have to get the supervising position, even if she's in an independent state. And so it's just going to hinder the formation of telemedicine, of these innovations here. Okay, and then lastly, the same type of story happens for new models of payments. So bundled payments and accountable care organizations have been encouraged by the Affordable Care Act. They have pilot programs going on. And both of these rely on cost savings within the physician groups. And so in order to really make these work, you have to be able to substitute labor where needed, right? If you can have a nurse doing certain things, let him, right? Substitute away from the expensive physician. Because none of this says anything about Medicare changing its reimbursement policies. Okay, so these scope of practice restrictions are again hindering the substitution and potentially blocking cost savings. Okay, so that's pretty much the end of my talk. These laws are far-reaching. We have evidence now that they improve labor markets, we can get higher levels of employment, more access to healthcare without the harm to the patients, and potentially with some improvements to health. We conclude that these laws are really just serving as non-productive administrative burdens that are going to protect the physician practice. And they can hinder the innovations in healthcare. And so the policy recommendation we come up with in this Hamilton project is that states shouldn't do this. You know, it's very simple, right? When we wrote this thing, they asked us to put a whole section about our policy recommendation, and we said, you know, states should just stop, right? That's it. They should just move to this fully enabled and be done with it. And we managed to stretch it out into a few pages, which I think was a good exercise in writing, but that's the main conclusion, is this, you know, let's move to fully enabled. There's no reason not to. So I will end there and take questions. There are plenty more.
Where do you think the areas are most sort of fruitful for research? I mean, if further research in this area, right? It seems like looking at specific provisions, given that there's no sort of standard coding of these scope of practice restrictions, it's sort of looking at specific provisions and specific health outcomes related to those specific provisions seem like something that needs to happen.
Exactly, yes. And I think if you look at the list of outcomes, that some of these make sense, right? And this is the conversations I've had with student researchers that I know are working on this, is that some of these are a little too specific. Infant mortality, this should not be related to scope of practice in any way, shape, or form. And especially because that particular study looked at NP scope of practice, not the midwife scope of practice, which, as I said, could be different. So yeah, we definitely need some ones that can be directly linked to the administrative costs. The nurse anesthetist, that's a whole other story, and that has good outcomes, right? You can clearly see what they're supposed to do, or you know, what kind of outcomes would be good and bad for that group. Nobody's looked at that to my knowledge. See, now I'm just giving you all my research information. What else? The physician's assistants, there's very little literature on them. Now, physician's assistants are a different group. They, by practice, work with a supervising physician. So the supervisory, eliminating that is not their optimal goal. Their optimal practice is to set up the relationship with their physician at the practice level. Because right now some states have some very strange laws when it comes to these physician's assistants. They'll say something like, all right, the physician has to be on site 4 hours a day, and the physician and the PA have to meet 10 hours a month. And the law specifically gives them details on these dimensions, which seems crazy if the practices might be 400 miles apart. You know, there's all that time in the car that the physician is driving just to satisfy the state law that's made by state legislators. So there's a lot of work, analysis that can be done for the PAs also.
I just had a question earlier when we were talking about having more nurse practitioners in states with lower scope of practice laws. Mm-hmm. Is there any evidence that there's less physicians in those states, if they're perfect substitutes in that respect, or in some respects?
That's a good question. So I don't think that anybody has looked at that.
Because that would be,
It
would be interesting to see if that actually reduced the number of licensed physicians.
Yeah, it would be. Or if it's just market expanding, right? So that's the question. Yeah, absolutely. It's a good question.
All right. Thank you very much.
All right.
I think the title of your talk sort of captures, these are the most important healthcare laws I've ever heard of. So thank you all for being here this week. Next week, Chris Herbst from Arizona State University will be here to present some work and an experiment that he's been working on with their adult tech and looking at the demand for child care quality. So I'll see you next week. Thanks.